it. It's a little distended, but not that distended. Is there any? I don't really see any very thick walls. You got your arrow on something.
No, I was just,
okay.
no.
I'm not super impressed by what I see. The colon, the walls are not that thick. Let me see if there's any place, any air anywhere in the wall of the colon. I'm also going to be concerned with that. I don't see any pneumatosis, at least on these windows.
Good, perfect. So let's give you multiple choices.
Okay. I didn't see any.
And there's if you look at
So, no.
a lot of these things you can throw right out the window, because this was what they were wondering about.
Right. So I didn't see any hematoma anywhere.
Correct.
I don't see a bile leak.
Correct.
I didn't see an abscess anywhere.
Correct.
There's no SBO.
Correct.
Ileus, I mean, sure, there can always be ileus, I guess, but not too impressed by anything. C. diff, you really expect to see some pretty thickened bowel loops, which I did not see. Malabsorption, I mean, sure. So I'm not really impressed by anything. Colon distension, pain medication,
So this is a daily case that you can get. The colon is distended, the patient's uncomfortable, and they're beginning to have diarrhea. This patient's getting a toxic combination of things. Pain medication they need. There's a little bit of post-op ileus that happens. The bowel isn't as strong. Malabsorption and steatorrhea. Well, the patient's getting high fat content feeding.
Yeah.
They go up to 45% fat just to give them an anabolic state. And this patient has pancreatic insufficiency because of the pancreatic tumor that was removed. So look at this, and then look at this. The colon is filled with undigested, unemulsified fat. And that's going to stretch the colon out. The bacteria that are there are overwhelmed. There's not even a lot of gas that the bacteria are able to produce. And so this patient is constipated. They're not able to move and squeeze, so they bloat and they're forming harder stools in the left colon. So remember the physiology of the postoperative patient, and if you have a G or a J tube, they can get into trouble with feedings, and you put narcotics on board in a patient with pancreatic insufficiency, and their pain may not be from their surgery. Their pain may be from their gaseous distension. Wean them. Cut down the feedings, cut down the pain medication to see if they need less, because sometimes they give more and more as the patient has pain from bloating. Increase the pain meds, and it just gets worse. Another thing that patients with G tubes and J tubes and any hole tubes in any tubes in their bowel wall will have postoperatively is tremendous pneumatosis. You'll have portal venous gas. You'll be ready to send the surgeon in. But when you have pain medication and a post-op ileus and a G tube or a J tube for any reason placed through, that tiny hole in the wall will fill every drop of venous blood with air, because the stomach is not affected with ileus to the degree that the rest of the bowel is. It's a stronger muscle and less susceptible. So it's going to be pumping that nervous air that the patient swallows into the jejunum, and it'll find that hole and it'll pump it up. And a long time ago, when I was a kid, we sent a patient to the operating room because it looked like it was pneumatosis. And there was pneumatosis of the small bowel, portal venous gas, and we said there's dead bowel. And the young surgeon listened to the young radiologist and operated. So that was a lesson that I learned the hard way. This isn't that case. All right. Any other questions? I think I am almost. My gun is empty. What is it? Let's get over to here.